Eli, a 3-year-old boy, has a complex medical needs. He has a Mickey button, G-tube for nutrition, tracheostomy with HME, which is heat moisture exchanger, Niacin fundoplication for reflux, peritoneal dialysis for end-stage renal disease, reflux development regression, and uses a chest vest for airway clearance, non-invasive ventilation at night. He's currently hospitalized for increased respiratory effort, feeding intolerance, and dialysis output.
Washing my hand, knock knock. Hi Eli, my name is Grace. I'm your CNA today. I'm gonna get your vital sign, okay? I'm gonna check your name and okay, Eli, and your date of birth is July 4, 2023. Okay, I'm gonna get your temperature and your blood pressure and also respiration. Here you go. Okay. And okay, I got the blood pressure. Okay, and your oxygen saturation. Okay, your nurse will be with you soon, okay?
Knock knock. Hello, my name is Elizabeth.
And I'm Rosalie.
Hi nurse, I just got his vital. So the patient temperature is 100.1, actually heart rate is 122, respiration is 38, blood pressure is 98/62, oxygen is 88 room air, and he gained 0.8 kilogram over 24 hours.
Okay, thank you. The priority is the airway, so I'm switching from HME to humidify the oxygen via a trach collar at 30% and reassessing the saturation. Can you, so here I'm going to place the trach collar, and can you please monitor the pulse oximetry?
Yes.
Okay. And I'm going to be listening to his lung sounds. Okay. Okay, and I hear the coarse crackles. He's working to breathe, so I'm going to prepare sterile trach suctioning.
Oh, hi nurse. So his O2 sat is up to 95 right now.
Okay, that's great. I'm gonna take a listen to his lungs right now. And I'm checking the breaths, and the breath still sounds coarse, but it has improved on the right. Given the RSV and secretion, let's start albuterol nebulizer first, then chest vest, then hypertonic saline, and suction again to see what we've mobilized.
Okay, I agree. I will coordinate with the RT, but for now I'll get the nebulizer going. I am going to start the albuterol nebulizer now. So, albuterol, check the name, date of birth, expiration, everything is good. The doctor prescribed for Mark. So, nurse, will you please hold him for a little bit while
Yes.
I'm gonna do this? Put the nebulizer for the patient, okay? And can you help him like keep this on so he doesn't take it off? Okay, thank you. Great job, buddy. You're doing good.
Knock knock. Hi, Nurse Elizabeth. I was gonna set up the meds for Eli via G-tube. Omeprazole before feeds and calcium acetate is a phosphate binder with meals, so I'll hold until the feed starts. And I'll verify the flush before and after and check residuals per policy.
Perfect, that sounds good. Okay, so the nebulizer is complete. Let's set up the chest vest every 4 to 6 hours as is prescribed. Let's run it for 10 to 12 minutes for the frequency and the pressure, and we'll watch for retching since he's post Nissen and had reflux.
Okay, so we put the weights on and turn the machines on for 10 to 12 minutes, and I'll be with the patient doing the procedure.
Great, so after the vest, I'll nebulize a 3% hypertonic solution and to thin the secretions, then we'll use the sterile suctioning again.
Knock knock. Hi, Nurse Elizabeth. I just wanted to let you know that I'm gonna pause the feeding until his breathing settles, and I'm also documenting strict I&O and daily weights since he's gained the 0.8 kilograms, and that supports fluid overload.
That sounds great. So I just did the suctioning as a sterile technique, and then he has a good clearance. And I reassessed the SATs and the work of breathing.
Yeah, and the oxygen now is 95, 96%, and the respiration is 32.
That's great. It's much better. So, okay, so let's keep the humidified oxygen for now, and we'll titrate later.
So upon observation, I've noticed the abdomen is mildly distended post-dialysis, and the PD catheter is clean and dry with no arrhythmia. So for excess fluid volume, we'll continue daily weights and strict INO to assess the edema, closely monitor PD effluent for clarity, color, and amount, use sterile technique for any connections or disconnections, and notify nephrology for any weight gain, minimal urine output, or crackles.
I agree. So let's also listen for new basilar crackles as the fluid cue and track the blood pressure trends.
Alrighty, and I'll cue the labs, which are gonna be the CBC, the BNP, the BUN, creatinine, and peritoneal effluent culture to rule out peritonitis.
That sounds great.
Knock knock. Hello team. How's Eli doing today?
Hello, doctor. So he arrived with the SPO at 88% on HME after O2 via trach collar and albuterol and chest vest, hypertonic saline, and sterile suctioning. He's at 95 to 96%, respirations at 32, and he has less retraction.
Yes,
Okay.
and his fluid status is concerning because he's gained 0.8 kilograms in the last 24 hours and has paraorbital edema and minimal urinary output. Abdomen is mildly distended post-PD, but the catheter site is clean and dry.
Okay.
We're sending BNP, BUN, and creatinine and PD effluent for culture.
Okay, that's good.
So-
So let's increase his peritoneal dialysis efficiency tonight, and maybe it's slightly longer dwell than 10% fill volume. Just confirm with nephrology once, and also add chest X-ray to evaluate for the fluid overload. And continue the chest vest for every 4 hours when he's awake, and also the albuterol nebulizer before the vest session. Okay. And keep omeprazole before feeds, and give him the calcium acetate with meal via G-tube, okay? And also please check his hemoglobin and hematocrit, and hold epoetin alpha if the hemoglobin is more than 12, okay? And also maintain the humidified oxygen via trach collar, and also plan non-invasive ventilation overnight. That's all for now.
Okay, we understand. So we'll continue with the airway plan, and we'll reassess oxygen need every 2 hours and after every treatment.
Okay.
And I'll call nephrology to confirm PD adjustments and place orders for this chest X-ray, labs, and the PD culture. And we'll continue sterile techniques for all PD handling.
Okay, so just in case for the parental teaching, just review the signs and symptoms of respiratory distress. Just tell them the retraction, nasal flaring, about fatigue, and the peritonitis, maybe fever, cloudy effluent, and abdomen pain. And I'll update the family after the labs, okay?
Okay.
That's good.
Okay, thank you guys. I'll see you
Thank you,
later.
doctor.
Respiratory status is steadier. I'll give omeprazole via G-tube now. Then we'll start Pediasure with calcium acetate at the beginning of the feed. I'll flush before and after with sterile water and check residuals per policy.
Okay, so we're gonna keep the head of the bed elevated 30 to 40 degrees during and about 30 to 60 minutes after the feed to reduce reflux. And because of the niacin, we'll vent the G-tube if he looks gassy.
So I will make sure that he's sitting upright during the meal and after the meal for 30 to 60 minutes.
Okay, so I'm gonna grab that omeprazole for Eli. And I'm gonna verify the 5 rights and document the dose and route via G-tube. And I'm gonna do the triple check. Good. And I'll head over to Eli.
Nice. So we'll reassess the breath sounds and his O2 saturations after the feeding, and because sometimes this tension worsens from the work of breathing.
Are we at scene
Hi,
6?
Mom. He's doing much better. So please give us a call if you see pulling at the ribs or if he's breathing really fast. if his head is bobbling, or if he seems too tired to keep up. Those are all signs of respiratory distress, like he's having a hard time breathing.
Okay.
And for dialysis, we're watching for cloudy drainage, fever, or intense belly pain, and those could be signs of peritonitis.
Okay, I will recheck the vital in 15 minutes help with the next west section, and I will monitor input and output.
That
for the
sounds
patient.
great. So please, for my delegation to you, take the vitals every 4 hours or as needed. Check for the oxygen trending. Set up the vest per policy. Elevate the head of the bed. You take the daily weight and report any abnormal values immediately.
Okay.
And for the RN, please use the sterile track suctioning, PD connect and disconnect, medication administration via G-tube, and assess before and after the vest and the lab follow-up.
Great. And I'm gonna go follow up with the doctor.
Perfect, thank you.
Who's calling? Oh, hello.
Hi, Doc. This is Rosalie at Unitech Hospital, and I'm with patient Eli Weber. And he's a 3-year-old with a trach. He has HME, a GT Mickey button, post-Nissen, ESERD on PD, and post-Wilms nephrectomy, RSV, admitted for increased work of breath, feeding intolerance, and PD output change.
Okay.
He arrived with an O2 sat of 88 on room air, which is now at 95 to 96 after airway interventions. Weight was increased by 0.8 kilograms in the last 24 hours with minimal urine output. The coarse crackles improve but there's mild abdominal distension, but the PD site is clean and dry. And I think we should continue on the albuterol and use the vest and use hypertonic saline and suction every 4 to 6 hours, and omeprazole before feeds and calcium acetate with feeds, strict INO, daily weights, and sterile PD technique. Labs and chest x-ray pending. PD dwell slot and fill increased tonight, and non-invasive ventilator at night.
That sounds good. So I will release after labs the chest x-ray, and also please call me if his oxygen level drops down below 92% despite giving him the oxygen, and also if his effluent turns cloudy or if you have any abdominal pain or fever, please call me, okay?
Alrighty, thank you.
Thank you. Have a good day.
Bye.